This conference will now be recorded.
ఇంత 50 అన్న 60 okay. Good morning everyone. So today my topic is about corrosive injury of esophagus and stomach. So coming to these topics, today we are going to discuss about epidemiology, types of caustic agents, pathophysiology, clinical features, diagnosis, outcome, and late complications and its management, prevention and treatment of strictures and esophageal substitutes. So around epidemiology, we see in this type of cases mostly around 5,000 caustic injections are reported in US. So not needed, but in India also generally most cases of esophageal strictures are due to esophageal ingestion of the caustic agents. It is mostly occurs due to accidental ingestions, mostly due to suicidal tendencies, or by children younger than 6 years of age. So in adults, occurs as a suicide attempts in patients with mental health problems in the intoxicated person as a result of alcohol and recreational drug ingestion. So adults can ingest larger amount of caustic substances, so they tend to have more strictures and is serious injuries than in children or infants, who will typically in infants they won't sedate or they cannot ingest the caustic agents, so they try to spit it out, so they throw up the caustic agents then they swallow. So two types of caustic agents are mostly commonly ingested, that is alkali and acidic agents. Alkali agents in household cleaners like drain, toilet bowls and oil cleaners. Fly is an alkali agent that contains sodium or potassium hydroxide. So caustic agents, these are alkali solutions are often odorless and tasteless and which can result in large amount that are being swallowed accidentally. So dysbacteria is also sometimes in children they they intake the disc batteries. So these are alkali substances. They induce alkali induced type of damage. So coming to caustic agents, acids, they are less frequent in Western countries and are more common in India. In India, they tend to ingest this Harpic and those are toilet cleaners like that agents. They tend Vim liquids like that they try to ingest. So those are they contain sulfuric and hydrochloric acids. So sometimes the anti-rust compounds that contain hydrochloric, oxalic, and hydrofluoric acid. And in a swimming pool, they try to ingest the bleaching powder like that for solution. They are hydrofluoric. So this causes immediate pain, which results in the agent, and they are being rapidly expelled. So due to the pain, the esophagus cannot substantiate the ingested acid, and it tries to belch out. That is, they cause severe belching, and they try to push the agent out. So coming to alkali and acid comparison between these two type of corrosive ingestion. So the pH is greater than 7 in alkalis and less than 7 in acid. And alkalis are generally tasteless and odorless when they are ingested in large amounts. So they cannot feel the taste or sense or odor. So they try to ingest the larger amounts in a gulp. So whereas in acidic, they have pungent odor and are very noxious in taste, so they cannot ingest in large amounts. So only small amounts they try to ingest. Okay, liquefaction necrosis. So in direct extension into deeper injuries, and coagulation necrosis is found in seen in acidic type of poisoning. So in solid form, that is limited quantities, oropharyngeal and supraglottic injuries only happen. It is in solid form, it is less esophageal injuries are seen. So in liquid form, sufficient significant quantities esophageal injuries, extension and circumferential burns is seen. So in liquid form, in that is in acidic type of poisoning, there is most of gastric injuries only. Okay. So coming to pathophysiology, what happens if alkali ingestion occurs? So when taken, the liquefaction necrosis occurs. It extends through the mucosa of the esophagus, then through the submucosa, following muscularis of the esophagus and stomach. And vascular thrombosis occurs following the necrosis of the tissue. What happens? That is the ultimate pathophysiological end process of the alkali injection, that is necrosis. So initial alkali injury can be transmuted and it can also result in perforation directly. So mediastinitis occurs due to the content present in the esophagus are transferred into the mediastinum, causing the mediastinitis. Sometimes it at the esophageal junction it enters into the peritoneum, causing the peritonitis, that is inflammation of the peritoneum. So external serving and ulceration occurs in a few days after the injection. Finally, extensive granulation tissue and fibroblastic activity and collagen deposition occurs over weeks, leading to chronic stricture formation. With alkali injection, the esophagus is most affected, neutralization by gastric acid, and it limits the damage in the stomach. So pathophysiological of acidic agents causes a superficial coagulative necrosis with thrombosis of the mucosal blood vessel. Acidic agents are more apt to damage the stomach, particularly the antrum, and more the esophagus, more than the esophagus. So this is the after the ingestion of the acid. This is the endoscopic picture where the squamous mucosa of the esophagus has turned out and sloughed in a linear pattern. So you can examine the linear ulcerations present over the esophageal mucosal wall, and it has bluish discoloration due to congestion. So this is the gastric mucosa being hemorrhagic and edematous following acid ingestion. So you can see the red hemorrhage, red color area hemorrhage and edematous other tissue in the endoscopic finding. So after the pathophysiology, the patient, how does he present to the OPD or casualty? The patient may present with severe esophageal oropharyngeal pain with epigastric pain sometimes, and he may also complain sometimes chest pain, and patient has dysphagia, unable to swallow anything, or odonophagia. So if there is only oropharyngeal involvement, it can cause cyalorrhea or drooling of the saliva. So coming to clinical features, hoarseness, stridor, and dyspnea suggest injury to the epiglottis, larynx, and upper airway tract. So it involves the airway tract. And persistent chest or back pain may suggest esophageal perforation and mediastinitis. That is, the due to perforation, the contents on the esophagus are passed on to the mediastinal, causing mediastinitis, inflammation of the mediastinum. And severe abdominal pain can be related to gastric perforation and peritonitis. So early signs and symptoms do not always correlate with the amount of caustic injury and likelihood for the late complication. On physical examination, patient may have evidence of burns in the oral cavity with edema and ulceration of the tongue and the surrounding structures, and there may be exudate present. But up to 20 to 45% will have normal physical examination sometimes. Okay. So what are the outcomes? So caustic properties, amount and concentration in physical form, duration of the contacts and treatment of the modalities. So coming to the diagnosis, an upper endoscopic examination should be performed in the first 24 to 48 hours, and after caustic injection in patient without perforation, it allows diagnosis of the injury to the GI tract and permits grading of the degree of the injury, establishes a prognosis, and can guide therapy. So in 40 to 80% of patients with a caustic injection, they will have no evidence of injury on endoscopic examination. But after 2 or 3 weeks, when the symptoms set in, they may have some reported findings, that is, they may present with esophageal strictures. So these are the types of gradings, but right now you may not need. But in general, Jargers and Kuykendalls are the two types of classification for caustic injection or corrosive injury of the esophagus. That is, in grade 0 in Jargers, normal mucosa, and grade 1 edema and erythema of the mucosa is seen. So grade 2A, hemorrhagic and erosive blisters, superficial ulceration is seen. In grade 2B, circumferential lesions, and grade 3A, focal deep gray or brownish black ulcerations are seen, and grade 3B, extensive deep black gray or brownish black ulcers are seen. And in grade 4, perforation. These are the endoscopic findings after injection of the corrosive agent. That is Argus classification. Okay. So difference between Zargas and Kuykendalls is mainly based in 2B and 2-3. That is, they will have grade 3A and B is divided in Zargas, and in Kuykendalls there won't be any 3A and B, but only 3 is present. So this is the Zargas classification on endoscopic examination. So you can see the normal mucosa, and this one is edematous, and it is discoloration, and this complete total corrosive type of poison. Okay. Coming to role of radiological examination. So chest X-ray and abdominal film, it may not aid because they only diagnose the bone tissue and other black and white appearance only. Bone tissue only they can find it, but soft tissue cannot be easily determined from the chest X-ray. It is in the diagnosis or rating of the severe injury, but will indicate the presence of perforation by showing pneumomediastinum, pneumothorax, or pneumoperitoneum. So CT of neck and chest and abdominal should be considered when a high degree of suspicion remains for perforation. When there is any mediastinitis, we should go for suspect for the perforation. And despite negative plain films, if perforation is present, surgery rather than endoscopy should be performed immediately. So it is a life-threatening procedure where immediate surgery must be performed in case of perforation. So this is the CECT and abdomen film. We are showing where the arrow mark points out the perforation. Okay. So this is barium esophagogram, where you can see the structural formation in the esophagus. Okay. This is also other barium studies showing the esophageal structure and constrictions. So coming to late complication. Stricture formation primarily in those with grade 2B or 3 injury. Peak incidence is seen in 2 months, occurs as early as 2 weeks or late as 3 years after injection. Gastric outlet obstruction, early satiety, weight loss, less frequently 5 to 6 weeks, and several years, usually acid injection. Late complication, incidence 1000 to 3000 fold increase, 3% have history of caustic injection, mean latency is 41 years, and scar carcinoma is seen in esophageal carcinomas. It is and followed by gastric carcinoma, which is a rare condition. In scar carcinoma, there will be lymphatic spread and there will be direct extension. So coming to the management. So immediately airway must be established first. It is the main priority, followed by chest and abdominal radiographs to repair perforation. If perforation is there, proceed for surgery. If perforation is not there, proceed for esophagogastroduodenoscopy for grading and further management. So once the management is the type of management is to be established, we initially stabilize the patient, and clinical status of the patient is taken, and grade of injury is seen in endoscopy. So asymptomatic patients who have normal endoscopic injury or only grade 1 or 2A injury can be started on oral intake. in the first 24 to 48 hours, and usually discharge within the same time frame. Generally, we look for any esophageal corrosive perforation in immediate examination. So if the patient is clinically ill, that is, he is having any hypertension, if he is any in respiratory distress, or if there is grade 2B or grade 3 necrosis, then he should be admitted to an ICU immediately and managed with IV fluid respiration and close monitoring for evidence of perforation. In the meanwhile, we should look for perforation also. So laryngoscopy should be performed in patient with respiratory distress. The patient with an edematous or a necrotic laryngopharynx should not undergo endotracheal intubation and will need a tracheotomy to maintain the area. So, viable esophagus and stomach, intraluminal esophageal stent and jejunostomy is done. So, if there is any questionable esophagus and stomach, second look at 36 hours after that, we should go for endoscopy again. So, full thickness necrosis of esophagus and stomach, we go for esophagogastric resection, cervical esophagectomy, jejunostomy, and resection of the adjacent involved organs. This is the surgical operative procedure in case of in severe injuries or in case of any perforation. Okay. So how to prevent strictures? Strictures, it is 100% up to 99 to 100%. Maximum it is seen in post-corrosive stricture formation. Okay. So we use steroids in animal studies to decrease the incidence of stricture formation. In humans, it is not yet inconclusive. So these are the journal studies they have given over the 18 years. They have no benefit on giving the steroids. Okay, antibiotics, sometimes it is useful because it decreases bacterial count, reduction in inflammation, and masks the sign of more severe infection. So prevention of strictures and nasogastric tube feeding and stenting is done. Contribution to the development of long strictures. Routine use is not warranted. Total parental nutrition, no human randomized study is done. And nil per oral allowing the reepithelialization up to 3 to 4 days. Patient is kept in nil per oral. So and intraluminal stenting and controversial prevents opposite raw surface contact and decreases stricture formation. So these are the types of stent, that is SEMS, that is self-expanding metallic stents is placed in the esophagus. So this is polyester mesh with silicone coating, polyflex. So how do we prevent of strictures? So early dilatation, that is within a week of period, but it is there are controversies on this study because it is not recommended sometimes because due to esophagus has occurred as severe pathophysiological changes. Sometimes it may cause perforation. So it is to be start during the first week. The stricture can resolve more easily. So in anti-reflux treatment and sucralfates can be given, that is PPI, proton pump inhibitors, and H2 blockers are sometimes given to reduce the acidic damage to the esophagus and prevention of the injured esophageal mucosa from gastric acid reflux. So these are the types of esophageal dilators where you pass the esophageal dilator with the help of a guide wire through the esophageal stricture when the dilator is passed behind it. So this is a Maloney dilator where after passing through that the stent is expanded. So the larger the dilators may be inserted. So after expanding after severe times of inflation of the bulb of the dilator, the stricture can sometimes give away. So treatment of strictures, endoscopic dilatation. The goal is to dilate the esophagus lumen to 15 mm. So the perforation rate is 0.5%. And special consideration, long eccentric strictures. Risk of perforation increases. Thick wall strictures which recur rapidly. And multiple sessions, elective esophageal dissection and intraluminal stent, that is temporary placement of self-expanding plastic stent. It is successful in case reports. So sometimes the strictures cannot be dilated purely or cannot be treated by endoscopic dilatation or intraluminal stents. So treatment of surgery is sometimes required in case of severe stricture, that is esophagectomy with colonic interposition and a gastric transposition with highly grade. So on placing the gastric transposition, the chance of leakage from the anastomotic site is very high. So it is to be performed 6 months later. So when do we go for surgery? When there is complete stenosis or cannot be dilated with stents, or there is marked irregularity and pocketing of the barium swallow, and mediastinitis or severe perioesophageal reaction on the dilatation, the fistula, perforation or marked dystosis or hemodynamic instability with systemic disturbances, and inability to dilate or maintain the lumen above a 40 French boogie, and patient unwilling or unable to undergo prolonged periods of dilatation if he insists on surgery. Okay. What are the various substitutes for the esophagus? In case of complete esophageal damage, we go for the substitutes, that is stomach or colon or right colon or left colon and jejunum. So free graft, greater curvature tube, reversed gastric tube and non-reversible reversed gastric tube, and sometimes myocutaneous flaps. These are the various esophageal substitutes, but most commonly used are stomach and colon, including jejunum. Okay. So, what are the criteria that are required for the ideal esophageal substitutes? Technically, it must be simple to reconstruct, and it must have minimal incisions and minimal number of anastomosis, adequate length to replace the excised esophageal segment, and reliable arterial and venous bed sampling allows normal swallowing, does not alter GI function, resistant to acid reflux, and durable with no long-term complications. Routes of esophageal substitution, that is posterior mediastinum, retrosternal, subcutaneous, transpleural, and endoesophageal. These are the various routes of esophageal substitutes. Okay. So, role of laparoscopy. Nowadays, each and every surgery is preferred for laparoscopy due to advantages of laparoscopy or the open surgeries. Lesser time of stay in the hospital, more recovery, immediate mobilization of the patient. Like this, several laparoscopic advantages are present over the open type of surgery. So what is the role of laparoscopic in esophageal strictures and esophageal corrosive injury? That is rapid assessment of the stomach serosa, and there is no resection required, and feeding jejunostomy can be done very easily. And the stomach and esophageal necrosis is greater than the subtotal esophagectomy and total gastrectomy. So the outcomes are greater than the surgical therapies. So in brief, what happens when a patient come with the corrosive injection to the casualty? So what this is the flow chart that is established. That is when the person comes with the corrosive injury within early admission, that is 40 to 72 hours, and delayed admission means 72 to 3 weeks, and late admission means 3 weeks. In early admission, if the lesions are mild at early endoscopy, then we can discharge him and ask the patient to come every month for follow-up. If the patient has severe lesions at the early endoscopy, that is within the early admission, we prefer for the surgical gastrostomy and the endoscopy dilatation after 3 weeks. So in case of delayed admission, that is after 3 days to 3 weeks, endoscopy is not performed. Gastrostomy is severe dysphagia. So endoscopy dilatation 3 weeks after injection. So after late admission after 3 weeks, then we go for endoscopy and dilatation. And if it is successful, we ask the patient to come every 1 month. And if the patient has unsuccessful dilatation or is having recurrence of the symptoms, then we ask the patient to go for surgery, that is surgical gastrostomy and retrograde dilatation of the 10 days. So, in conclusion, signs and symptoms alone are unreliable guide to injury. So, an early endoscopy has a crucial role, and grading and then manage appropriately. Surgical treatment is a good option in patient with severe strictures, and colonic intervention might the best surgical process. Okay. Thank you.